Conference
Here
will
and
now
welcome
be
everybody.
recorded.
Yes. Oh, welcome everybody to the Curious Cases webinar from January 2026. My name is Camila Ursua Fresno, and I am a assistant professor at the University of Colorado in Denver. I put some cases together to show you all, and this is supposed to be an informal teaching session, so feel free to just jump in with comments and questions. The idea is to make it fun and interactive. If there's anybody who wants to take any cases, you are also very welcome to do so. Okay, can you all see my screen? I just want to make sure. You can see it? Yeah, great. Okay, all right. So let's get started. All right. So case one, these are CT images, axial images at the top and at the bottom, and then a sagittal image at the bottom right. This is a 71-year-old male who had a complex medical history. He had a history of systemic hypertension, COPD, and arrhythmias, atrial fibrillation, and heart flutter, unprovoked PE, and a previous stroke. And he presented with dizziness that actually got worse when he stood up after starting a new diuretic. So it was interpreted as orthostatic hypotension, but still he had some chest pain or chest discomfort. So this CT was obtained. Do we have anybody that wants to take the case? Okay, well, if there's nobody, I'm happy to describe the findings. By the way, his blood pressure was a little on the lower end, 96/67, and otherwise he was afebrile and he was setting 91% on room air. And as you can see on the top images, there is a dilated pulmonary artery that was measuring approximately 3.8 centimeters in this patient. There was some eccentric filling defects noted in the left pulmonary artery and also extending into the left lower lobe pulmonary artery. I don't know if you can see my pointer right there. There was also some tapering of segmental vessels in the middle lobe that were not filling properly. So that caught my eye. And also, if you take a look at the bottom images, there is a funny looking shape of the interatrial septum. You could see it sort of bulging towards the left. That is called an aneurysm of the interatrial septum. And there was some contrast pooling on the left side, on the left atrium, as you can see across the septum. And when you looked at the sagittal images, you could see a defect in the interatrial septum with a jet of contrast directed anterosuperiorly. Any thoughts on what this could be? If we don't have anybody who wants to participate, that's fine. I just put a few here in this slide. People could think there's defects in the pulmonary arteries. Maybe this is an acute embolism, or maybe this is a chronic embolism, given the presence of pulmonary hypertension with a secundum ASD, with a shunt going left to right. Or this could be also a case of chronic embolism, but with a patent foraminal valley with a right to left shunt. And that was actually the case. This is a CTEPH case, which is chronic thromboembolic pulmonary hypertension, because these defects were peripheral, were eccentric, right? There was some tapering and narrowing of some vessels in the middle lobe. And this defect in the interatrial septum is actually going the opposite way, right? It usually ASDs go from left to right because usually the increase in pressures, the pressures are higher on the left side. But in this case, given the increased right-sided pressures, the flow is reversed and the shunt was going from right to left. So just a few words about chronic thromboembolic pulmonary hypertension. This is just another slide where you can again see the findings with that nice shunt going from right to left. Um, Chronic thromboembolic pulmonary hypertension, basically it happens after you get uh, uh, chronic embolism that doesn't resolve, and that can go on and cause vasculopathy within the lung due to the increased wall shear stress, and that results in increased pulmonary vascular resistance that overall in time causes pulmonary hypertension. And we diagnose that. Basically, we measure the main pulmonary artery. It should be less than 29 millimeters in men and less than 27 millimeters in women. So when that is dilated, that is something of note to note in the report. And it should be associated with signs of chronic embolism, right? So eccentric filling defects, abrupt narrowing and stenosis of vessels, web-like filling defects, and sometimes total occlusion. You can find abrupt occlusion of a vessel as well. The increase in pulmonary pressures results in backward increase into the right-sided chambers, right? So you can see a dilated right heart and also signs of right ventricular hypertrophy, which includes a thickening of the right ventricular wall of the moderator band, increased trabeculation, etc. And we also find in these patients mosaic attenuation. These are findings in the lung. That mosaic attenuation is caused by areas that are oligoemic, right? Areas that have reduced blood flow due to the chronic emboli, right? And the normal areas may be normal or hyperemic because of the redirectionality of flow. And the attenuation actually increases homogeneously on expiration. And that's how you differentiate it with small airways disease, which can also have mosaic attenuation on CT. But the vessels, interestingly, are the same size on both areas of hypoattenuation and areas of increased density. It shows you that the cause is not a vascular cause, right? And when you have expiratory acquisitions, those areas of air trapping are more lucent when compared to the remainder of the lung. So that's sort of how you differentiate both. And you can also have lung scarring in these patients if they've had prior infarcts associated with their emboli. You can find areas of scarring and atelectasis as well. Just a reminder that UCSD published a surgical classification for CTEPH. Not everybody uses it. I find it quite helpful. It's based on the most proximal extent of the thrombus, and it's used to direct surgical management. So level 0 would be no thromboembolic disease on either lung. Level 1 would be lesions starting centrally in the main pulmonary arteries. Level 2 would be lesions starting at the level of the lobar arteries. And level 3 would be segmental, and level 4 would be subsegmental. So some people find this useful. So the providers, your surgeons know exactly what you're talking about, what level of thrombosis we are talking about. Related to the case that we saw, right? So what happens when you have an ASD and you have pulmonary hypertension? The extreme manifestation of this is Eisenmenger syndrome, and this is a companion case. This is not what happened to our patient, but it's a complication where the patient results in pulmonary hypertension with reversal of flow of an existing intracardiac shunt. So in the first case that I showed you, we had a PFO that had flow from right to left. Usually ASDs, primum and secundum have flow from left to right because pressures are higher on the left side. But when you have pulmonary hypertension that results in a reversal of this flow, that is known as Eisenmenger syndrome. And it can occur with ventricular septal defects or atrial septal defects, also with patent ductus arteriosus, pretty much any intracardiac shunt. And patients often present with fatigue, dyspnea, chest pain, and syncope. And this is a very nice case that Dr. Carlos Restrepo, I borrowed from him, and you can see this large pulmonary artery in the X-ray, and the corresponding CT shows a massively dilated pulmonary artery, and this ASD, this secundum ASD, a wide open defect in the heart, and you can also see the enlarged right heart chambers. This is another very interesting companion case that I thought I would show you. This is in the setting of acute embolism, though. But in the patient who also had a PFO, just like our first patient that we saw, you can see on the first image, axial image on the left, there is extensive burden of embolism involving the distal right pulmonary artery and extending into the interlobar artery, probably the right lower lobe and middle lobe arteries as well, because I see those little stumps over there. And you can see linear thrombus in the middle image in the right atrium actually crossing into the left atrium, right? This is a case of transeptal paradoxical embolism. And this is very serious and puts the patients at risk for stroke, right? This was a 58-year-old female patient, and indeed, she was developing neurological symptoms. Okay, that's case one and companion cases. Let's do case two. Do I have anybody, any volunteers who want to take the case? Okay, I can take it myself. Everybody's feeling very shy today. That's fine. So we have some axial images of a ECG-gated cardiac CT, the top two and the bottom left. And then the bottom right image is a 3D volume rendered reconstruction. I'll start at the top. So we can identify the aorta and the main pulmonary artery. And as you can see, or I beg you maybe follow me, you can see the LAD coronary artery there that is supposed to originate from the left main, and you see a little bit of the circumflex artery. So those two arteries are there. You see at the bottom left a normal origin from the RCA from the right coronary cusp, but the origin of the left main is not very clear. Okay, and in the volume rendered image at the bottom right, you can see that's the right coronary artery, the big artery there. That's the right ventricle, and you can and the pulmonary trunk, and you can see some collateral vessels crossing across anterior to the pulmonary artery and the right ventricle towards the left side. Let's look at this axial recon as well. Same findings. You see the origin of the right very clearly, right? And the RCA is a little bit dilated, but the course of the RCA is normal. Let me play that again. Yep. But the origin of the left main is not very clear. And actually, it does not seem to communicate to the left cusp. So let's go to the next one. So again, any thoughts on the differential diagnosis? I put a few hypotheses here. One option would be anomalous origin of the LAD, coronary artery, anomalous origin of the circumflex coronary artery, a single coronary artery, and atresia of the left main coronary artery. And this case was an atresia of the left main coronary artery, and I will explain why. So congenital atresia of the left main is an extremely rare congenital anomaly. The most I could find online was about 33 reported cases worldwide, and the left main trunk ends blindly, just like you see there in the image. And either the LAD of the circumflex, the blood supply comes from collaterals from the RCA, right? So that's why the right coronary artery was plump and dilated, because it's actually supplying the left side too, because the left main is not coming from the cusp, is not connected to the cusp, right? What could be other differential diagnoses, right? At the time, I thought, is this an atherosclerotic occlusion of the left main? Because that would be, common things being common. Atherosclerotic coronary disease, it's more common than these findings. But the patient actually did not have any coronary atherosclerosis anywhere else. And the other alternative would have been, the closest one would have been a single coronary artery. And how do we differentiate these two? So the single coronary artery, the flow is always centrifugal and goes from bigger to smaller arteries, right? And it just, there's one single artery, and it throws branches to the right, to the left, and the flow always goes from the center to the periphery versus retrograde flow in the left main coronary artery atresia, because the left main is not connected to the cusp, flow is coming from the right and reversely coming towards the left side, right? And thus, nearly 100% of patients will develop myocardial ischemia or symptoms of ischemia. And some of them may present with sudden cardiac death. So this anomaly definitely requires surgical correction. Please interrupt me or comment if you like. This is supposed to be very informal, really. So feel free to just jump in if you want. So coronary artery anomalies, I know this is a very busy chart, but bear with me. They are quite rare. The one that I showed you is much rarer, but the overall coronary artery anomalies have a prevalence between 0.4 and 1.5%. In the general population. They're usually asymptomatic, but some of them, as you saw, could be life-threatening. And the anatomical findings are important for us to include in the report for surgical considerations. Cardiac CT has been the cornerstone of diagnosis and characterization. Before, all these patients were diagnosed, with invasive angiography, and now CT is so readily available that we see them, and we see them more often than we thought, actually. And the great thing about cardiac CT is that it can also identify high-risk features that are associated with these anomalies. For example, the presence of an interarterial course or a slit-like origin, which is significant narrowing at the origin, the presence of acute takeoff angles, intramural courses, etc. Right? And thus it can point to the urgency or the need for non-invasive functional testing. If you find any of these, the correct next step would be to send the patient to functional testing, either by SPECT or by stress echo or CMR. And then the idea is to check for the presence of reversible ischemia, right? However, even if patients don't have reversible ischemia, if they are younger than 35 years old, usually they go for surgical revascularization, right? And this chart that I put right there, it's a very nice chart from Radiographics from De Padua. It was published, a very nice review on coronary artery anomalies in 2024. And they divide these anomalies of origination and course, anomalies of intrinsic coronary arterial anatomy, anomalies of termination, and the presence of anomalous anastomotic vessels. So just as a summary, if you have anomalies of origination and course, those include originating in the wrong cusp, right, or anomalous location, originating from the sinotubular junction, right, or the presence of a single coronary artery that supplies both ventricles, right. Anomalies of intrinsic coronary arterial anatomy, maybe the ostium is abnormal, maybe there's coronary ectasia or aneurysms. This case has an absent coronary artery, so I guess that would be our case, which is the atresia of the left main, right? And muscular bridging, right? That's an anomaly also, could be also considered an anomaly, of course. And then coronary termination, right? That's the category that would include fistulas, right? Or inadequate arterial or capillary ramifications, etc. So these are just two companion cases. Let me just play them for you. So on the left, they're both axial recons of cardiac ECG-gated cardiac CT. And the one on the left, you can see an anomalous origin of the right coronary artery from the left cusp. That's going to keep on playing, so you can look at it again, with an interarterial course. So it's originating from the left cusp and it's traveling, let me see if I can play that again. It's traveling between the two major arteries and into the right AV groove. In this case, the origin was not slit-like, it was just mildly narrowed, but still the interarterial course is a risk factor. So it went to surgical correction. And the recon on the right shows anomalous origin of the left common left coronary artery from the right cusp with a prepulmonic course. So it's gonna go again. Let me just play that again for you. You can see that artery looping anterior to the pulmonary trunk and into the left AV groove. And this one, the prepulmonic course is what is so-called a benign course, right? It does not need surgical correction. Okay, let me go to the next slide. There we go. Okay, questions, comments? Nope, let's move on then. Case three. Case three, it was a 57-year-old male that consulted for dyspnea on exertion. On preoperative workup for spinal surgery, he had some other issues that revealed an abnormal echo. So that followed by a stress test, and the stress test actually showed an old anterior wall infarct and then lower left ventricular ejection fraction. So this is part of the workup of that study. This patient did not really have any cardiac symptoms, but because of this workup ended up in cardiac CT. So let's see what this recon shows. Lots happening in this CT. I don't know if we have any volunteers that want to take this case.
I can take it, Cami.
Sure.
So right on the actual images, we see a lot of collaterals in the mediastinum. And as we scroll to the heart, we see that the coronary arteries are dilated, and I can see that the LED is arising from the pulmonary artery. You see that? Yeah, right there.
Nice. Yeah.
And the RCA is very significantly dilated, so there might be reversal flow into the RCA. Um, so yeah, this is an alcapa.
Yes. That's wonderful. Great. Thank you so much. So yes, and actually this patient went into invasive coronary angiography as part of their workup, and the cardiologists were very concerned because they saw what they thought was actual retrograde flow into the LAD, right? Which was concerning for Al-Kappa. So again, these were all the possibilities, and you hit the nail on the head. This was an anomalous origin of the left coronary artery from the main pulmonary artery. And okay, so Al-Kappa, right? It's also known as Bland-White-Garland syndrome. And as we already mentioned, it's an anomalous origin of the left coronary artery that supplies both the LAD and the circumflex from the pulmonary artery, right? It's rare. It's between 0.2 to 0.5% of all congenital cardiac anomalies. So it means that the actual prevalence is much lower. And the reason why this is important is because it is associated with coronary steal phenomenon, right? It produces a left to right shunt because the pressures are higher on the left side, even though the coronary arises from the pulmonary artery, actually the flow goes backward. And you could see on the previous images that the contrast is actually going into the pulmonary artery rather than the flow coming from the pulmonary artery to the left coronary artery. The flow actually goes in reverse direction. And that results in abnormal ventricular perfusion and therefore needs surgical correction. So at the bottom there, we have again, from this really nice article from De Padua, they have nice illustrations, the infant type and the adult type. And basically they differentiate themselves by the presence of collaterals. In adults, the adults have had time for the heart to adapt to this anomaly. So they develop prominent collaterals between the right and the left side because of the shunt. But in the infant type, which has a high mortality, there's no collaterals, right? So the babies cannot adapt. And if it's a significant shunt, actually 90% die within the first year of life, which is very sad. And in the adult type, as patients present with chronic myocardial ischemia, right? There's a chronic steal phenomenon that results in ventricular ischemia, dysrhythmias, and it can also present with sudden cardiac death. In these patients, direct reimplantation of the coronary artery is the best surgical approach, allowing for a favorable anatomy. If the coronary can basically stretch enough to reimplant into the aorta. But otherwise, when the anatomy it does not allow for direct reimplantation, an intrapulmonary aortocoronary tunnel or baffle can be attempted between the aorta and the origin of the left main, but that is within the pulmonary artery. So it's a complex surgery, and it has higher risks of complications like pulmonary artery stenosis and leaks. And that's called the Takeuchi procedure, by the way. So just a comparison between the L kappa and the R kappa. So you can have this on the right and the left side, right? So the L kappa, we mentioned it's the anomalous origin from the left coronary artery from the pulmonary artery. R kappa would be the anomalous origin of the right coronary artery from the pulmonary artery. L kappa is 4 times more prevalent than R kappa, but both of them are associated with left to right shunts. It is less symptomatic on the right than it is on the left, but it still requires surgical correction because it can result in myocardial ischemia as well. And on the right, it can also be associated with other congenital defects like ASDs, VSDs, and more complex congenital heart disease like tetralogy. So this is just a volume rendered recon of an R kappa. You see that that's the pulmonary artery because that's the RVOT, that's the right ventricle right there, and this large artery on the right AV groove, instead of arising from the aorta, it's actually arising from the pulmonary artery. Okay, case 4. All right, any volunteers? Anyone? Okay, I'll just go ahead and describe the case, and as we go, feel free to just jump in if you like. This is a 55-year-old male with unknown previous medical history, and they presented after an unrestrained high-speed motor vehicle accident. They actually crashed into a tractor, which required extrication. It was a very bad crash. And upon arrival to the emergency department, the patient was conscious. He was Glasgow 15, but he was tachycardic. There were signs of flail chest on the examination, and there was suspicion for vascular injury, and that's why the CT was obtained. And you can see axial images of a CT angio that was obtained at the time. There are several rib fractures noted. There were some spinal fractures as well that I wasn't able to include. And I guess the main finding that I want you to see is to look at the aorta. So when we go top to bottom and looking at the mediastinum, you can see that there is hypoattenuation surrounding the great vessels, mainly the left common carotid and the left subclavian, and that is extending into the aortic arch. And also into the descending aorta all the way down. Also, the proximal descending aorta or distal arch has a defect, a hypoattenuating linear defects extending into the aortic lumen. I'm not sure, I'm hoping you can see this. And on sagittal reconstructions on the right, you can see there's an outpouching of that proximal descending aorta, the inferior aspect of the aorta, which is also surrounded by this hypoattenuation around it. So, any thoughts?
Like a traumatic
Yeah,
pseudo-A? Or
that's a great thought. What else?
it could just be like rupture, like transection.
Yeah. So, okay. There's a sternal fracture as well. I forgot to point that out. Okay. Yes, you're on the right track, right? So we're talking about aortic injury, right? So I just put here some differential diagnoses. Someone could think maybe this is a dissection because there's like a linear hypodensity that could potentially be a flap, or acute aortic injury, grade 1, or a pseudoaneurysm, right, which would be grade 3. Acute mediastinitis is also there in the differential, giving the fat stranding and hypoattenuation. And I think you got it. This is an acute aortic injury, and it has both grades 2 and 3, and I'll explain why. So acute traumatic aortic injury is graded 1 to 4, and this is by the Association of Thoracic Surgeons here in the US. And number one being the intimal tear, so that would be only a tear just like the ones that we saw actually there at the beginning. You could see a tear in the aorta. Grade 2 would be an intramural hematoma, which is what I think this patient had, all the way from the arch and into the descending aorta. But they also had an outpouching that you pointed out, right? In the proximal descending aorta. That's a pseudoaneurysm, and that's grade 3 or contained rupture. And 4 would be free rupture, which means there is literal extravasation of blood from the aorta into the mediastinum or into the pleural space. So these are caused more often by blunt or penetrating trauma. And the tip here is to look for other signs of traumatic other signs of traumatic injury in the chest that could potentially suggest a vascular injury. So, a high-speed motor vehicle accident or a fall from several floors could give you sternal fractures, scapular fractures, right? When you find that there's a lot of energy involved in the trauma, that's when you have to actually suspect if there is vascular injury as well. And why does this happen? Because of the rapid deceleration forces, right? And they're most common in the aortic isthmus, which is where the ligamentous arteriosus is, but also in the ascending aorta and in the diaphragmatic hiatus. Basically, is where the aorta is fixed, right? So when the aorta is fixed and then you have a rapid or a deceleration, that's what causes the injury, right? And aortic dissection, I put it in there as a differential, but really dissection is rarely a sequela of trauma. So let me just go back just to see. This would be 2 and 3 because they have the pseudoaneurysm there and they also have the intramural hematoma. So it's a combination of both. Okay, case 5. So this is a patient, a 31-year-old female. She was status post Ross procedure in 2023 for bicuspid aortic valve. And unfortunately, she developed an aortic dissection. You can see that dissection flap there in the ascending aorta. And this was back in 2023. And then she came back now this year again in September 2025. And the findings have changed a little, right? She had this chronic dissection that we knew about, but the flap was now thicker and extended a little bit further into the arch. But there's also another finding. I'm not sure if anybody can point it out. I'll just give you a hint.
There's like
Yeah,
a
go ahead.
fistulous connection between the aorta and the pulmonary artery.
Perfect. Yes. You can see the middle and the bottom right image, and there's actually a jet of unopacified or less opacified blood, right? Because there's a little bit more contrast in the pulmonary artery at this point. From the aorta into the pulmonary artery, there's a defect in the wall, right? Yeah, so this patient went to surgery, and actually they found the chronic dissection. They found a contained rupture of the aorta with separation of the hemishield from the pulmonary artegraft because the pulmonary artegraft was there because of the Ross procedure, and it was complicated by an aortopulmonary fistula, right? And this was later solved by a Bentel and a pulmonary artery plasty. So yeah, this was a chronic aortic dissection with aortopulmonary fistula, also super rare. Let's talk a little bit about this. So it's in the setting of dissection, it's an exceedingly rare complication, right? But it can be life-threatening again because there's an acute left to right shunt due to rupture of the false lumen into the pulmonary artery. It's actually more common in the acute setting, in acute dissection versus chronic, but this was a case of chronic dissection, and it requires surgical repair. What other complications of acute aortic dissection we need to keep in mind? And this is just sort of a companion discussion, but I think it's quite relevant. So when you have an aortic dissection, watch out for dissection or occlusion of branch vessels, right? You can have the dissection flap extend or migrate, right, into one of the origin of the branch vessels, causing organ ischemia. You can have rupture of the aorta into the pericardial sac with hemopericardium. You can have coronary artery occlusion, which would be an emergency, right? And the right coronary artery is actually more affected than the left. You could have extension of the dissection flap into the aortic root, causing acute aortic valvular insufficiency. And you could also have the hematoma extend into the pulmonary arteries because they share a common sheath, right, within the pericardium. So in the bottom right there, you can see the non-contrast image. And at the top, you can see the contrast image, both of them axials on CT. And you can see the hyperdensity surrounding the aorta, but also surrounding the main and right pulmonary artery. So that hematoma is actually extending into the sheath of the pulmonary arteries. And at the top image, you can also see the hemopericardium as well. This is another companion case. Things can go really wrong sometimes. And this was a patient who actually had history of a prior aortic valve replacement and ascending aortic graft repair. And he came into the ED because his hemoglobin started dropping. So he was sent for us for evaluation. Um, and he had significant coagulopathy. His hemoglobin dropped to 4.8, and they required significant transfusions. And you can see these three images again, CT. The first two are axial images, and the third is sort of like an oblique recon. It's sort of axial oblique. And you can see in the non-contrast image that hyperdense, hematoma surrounding the ascending aorta. There's also hemopericardium on the mid image, and you can see the actual active extravasation through the graft of the ascending aorta into the periaortic space. So that was definitely also uh, needed surgical correction. And other findings in this image, you can see, opacities in the lungs. This, unfortunately, was also complicated by aspiration pneumonia in the same patient, but that's unrelated. Okay, case 7. Do we have any volunteers? I can go through and let's see what y'all think. Okay, so this is a cardiac MR case because we've done a lot of CT, so I figured why don't we do a little MR as well. We have some cine images at the top left. We have some late gadolinium sequences on the right, top and bottom, 3-chamber, 4-chamber, and short axis images. And then at the bottom left, we have T1 and T2 maps in short axis at the base. So let me just see if I can play the top one. Okay, so this was a 58-year-old female. She had symptoms of heart failure. She was already a known patient to the cardiology service, and she had severely hypokinetic anterior and anteroseptal walls with a left ventricular ejection fraction of about 31. On the tissue characterization on the T1 and T2 maps, there was elevation of native T1 values for around 1292 milliseconds. And there was also elevation of T2 and the septum, around 67 milliseconds for us. As well, both in the in the anteroseptal and infraseptal segments, and also extending into the mid septal segments as well. And when you go to look at the late gadolinium enhancement sequences, you see extensive subendocardial and patchy late gadolinium enhancement predominating in the septum, both basal to mid septum, also extending into the apical, septal, and inferior segments, and a little bit patchy inferolateral as well, you can see on the 4-chamber view. So prominent LGE in this patient. And, this patient, unfortunately, she arrived with ventricular tachycardia and cardiogenic shock. She was really, really sick. Unfortunately, this patient developed ischemic bowel due to the cardiogenic shock and passed away after the family declined any intervention. So, thoughts?
It's kind of a very extensive LGE, um, all with
Yeah,
the
let
septum,
me
but
give
also
you some hints. Yeah. So one option would be, because it was septum and anterior wall predominant, is this an LAD territory infarction? Is this a myocarditis? Particularly, I gave you giant cell there. Is this a cardiac sarcoid case? Or is this a genetic cardiomyopathy? What are your thoughts? It's a little bit hard, I know. But in this case, this one was a giant cell myocarditis, and we'll sort of review why. Giant cell myocarditis, and these are images from the same patient. It's fulminant, rapidly progressive acute myocarditis. It's actually rare. It's about 0.5% of all myocarditis cases. And on path, it's characterized by prominent myocyte necrosis with diffuse inflammatory infiltrate and multinucleate giant cells, but no evidence of granulomas, right? Unlike sarcoid. They can develop acute heart failure, cardiogenic shock, and ventricular arrhythmias, just like this patient did. And on CMR, what do we see? We see left ventricular dysfunction. We see elevated native T1 and T2 relaxation values. The elevation of T2 actually tells you there's acute inflammation. So that would give you like the hint that this is probably a myocarditis case. It can also be seen, edema can also be seen in acute infarction, but just the pattern of enhancement was not really subendocardial or restricted to a single coronary territory, right? It was involving basal to mid septal segments, but it was also involving a little bit of the lateral wall as well, and it was quite subendocardial and patchy. So it did not match any ischemic involvement, but I give you that this one was a very extreme, extensive case. And, I found this really interesting. I found a study from Finland, from the Registry of Myocardial Inflammatory Diseases, and they did a comparison between their giant cell myocarditis and their cardiac sarcoid cases, because cardiac sarcoid could have been a really good differential here, right? They also predominate in the septum. So out of all the registry that they had from 2007 to 2018, more than 11 years, they found 33 cases of giant cell, and 18 of them had MR. So they got 18 cardiac sarcoid cases as controls, and they found that the CMR cases are actually indistinguishable. They're pretty, they predominate, they have a very similar pattern, basically, of subepicardial and patchy enhancement that predominates in the septum, has that hook sign sometimes that extends into the right ventricle, right? And it can also be patchy in the lateral wall. In comparison, the only thing that they found that was a little different is that giant cell had a little less LGE for comparable left ventricular dysfunction. So usually cardiac sarcoid had more LGE for the same LVEF. But sometimes these are hard to differentiate, and the diagnosis has to be done by biopsy or necropsy in this case. And a companion case, case 8. So this is a 49-year-old female that presented with new heart failure, global hypokinesis on echo, some arrhythmias. The LVEF was 49%. She also had global hypokinesis, and after motion correction, because there's a little bit of motion on the maps, she did have elevated native T1 and T2 values. T1s were around 1150, and T2s were around 72 milliseconds, and more elevated in the mid-inferior septal segment. So you have long axis T1 and T2 maps at the top. You have a T2 haste at the top right. And then at the bottom, you have late gadolinium enhancement sequences in short axis, the first 3, and a 2-chamber PSIR in the bottom right. And you can see that there is areas of subepicardial and sometimes even almost transmural LGE predominating in the basal anteroseptal, mid-infroseptal, and inferior segments, and also extending into the apical inferior segment. And I put there also the T2 haste because the patient had some prominent lymphadenopathy in the mediastinum and also in the hyla bilaterally. And so she went to PET CT, FDG PET, And FDG PET showed increased metabolic activity in the septum and in the apical, like in the apex and apical lateral wall, and also showed multiple lymph nodes that had increased FDG uptake. So any thoughts?
Like the sarcoidosis?
Yeah, thank you. This is a cardiac sarcoid case, right? So just a companion case to the giant cell. They're very similar. The giant cell has a more fulminant course clinically and maybe more edema, but they affect similar. They have similar enhancement patterns, right? Cardiac sarcoid usually occurs in the setting of systemic sarcoidosis. So you already know that the patient has pulmonary nodules or they have mediastinal lymphadenopathy, but it can also be the first manifestation in about 5% of patients. It can present as acute myocarditis, or it can also present as chronic LV dysfunction. And when you look at it on path, it does have well-formed granulomas, unlike giant cell, right? You can also have, clinically, you can have elevation of angiotensin converting enzyme and a positive FDG PET, CT or MR, right, with active myocardial inflammation. And what do we see in MR? Patchy and nodular LGE greater in the basal left ventricle septum, also involving the RV insertion points like we saw, but it can also affect, have like a patchy and involvement of the basal inferolateral wall. Interesting fact, one of the things that I find very useful is that a lot of these patients develop with arrhythmias, and you can actually see that as septal dysynchrony. You can see new bundle branch blocks. We get lots of these, query myocarditis or query cardiomyopathy, new bundle branch block, right? And when you see septal dysynchrony and matching LGE in that area, cardiac sarcoid should come up as one of your options, right? You can also see hypokinesis of the left ventricle, reduced ejection fraction, and in the case of acute myocarditis, in the setting of sarcoidosis, you can have elevation also of native T1 and T2 values, right? Just also LGE, just to keep in mind that LGE is a strong independent predictor of cardiac and all-cause mortality in patients with myocarditis and with sarcoid. So the burden of LGE is also an important prognostic factor. And this is just a reminder if we have any trainees watching as well. These are the revised Lake-Louise criteria for myocarditis. So whether it's sarcoidosis related myocarditis, or it's giant cell, or it's viral, right, or post-COVID, right, we do need one T1 and one T2 criteria. So at the top, we have the T2 criteria. So you could have either elevated T2 signal on the STIRS, or you could have elevated T2 values, relaxation values, and you need to have at least one T1 criteria, right? Which is either the presence of LGE in a non-ischemic pattern, or the presence of elevation of native T1 values or extracellular volume, which represents replacement fibrosis, right? So if you have one of each, that is already enough for the diagnosis of myocarditis. So you can have edema and elevated T1s without LGE and still have a positive case for myocarditis, right? You don't need both T1s, for example. You don't need LGE and T1s, either one T1 and one T2. And we also have supportive criteria that are not diagnostic, but it does help, right? So the presence of, a reduction in LVEF, hypokinesis, or associated pericarditis, right? That would make it a myopericarditis case. Those are all supportive as well. And there's a very nice paper from Dr. Sanchez and the Toronto group in Radiology Cardiothoracic Imaging from 2021. And with that, I am finished. And I thank you all for your attention. And thank you for being here.
Thank you so much.
Any questions, comments?
Thank you. Really nice cases, Cami. Thank you.
Thank you so much.
Thank you very much. This was wonderful.
Thank you.